Now we have a proper indication to place a pig tube. In real life practice, I highly recommend that the moment you think that this patient may require pig tube, you should start thinking about initiating family discussion. Any contraindications, any blood thinners need to be held. How is that? Let me give you an example. I have a patient who admitted with an ischemic stroke, for example, and clearly to me from day 1 or day 2 or even day 3, and after consulting with speech therapy, that he's not going to be able to swallow anytime soon, and I roughly estimate that this patient may need a few more weeks or months. And always when you talk to the family, never say for sure, always say possible, likely, most likely, less likely, probably. Never use any absolute terms. So this patient, I don't have to wait for 2 weeks while having NG tube and then to say, hey, he needs a peg tube. After the first few days, if I don't see any improvement, I should initiate the family discussion, even if the patient has an NG tube. And the way I'll start this discussion is by telling them, the way this patient look, or talking to the patient himself, I don't see you would be able to swallow safely anytime soon, and we really need to have a more secured long-term source where you can receive your nutrition and medication until you're able hopefully to swallow soon. Because the nasogastric tube, you need to explain to them that, otherwise they will get confused. Why to have this tube if we have the tube in the patient nose already? Because we cannot use it, as you remember the NG tube, we cannot use it roughly more than 2 weeks because the risk of wounds, necrosis on the nasal area, and gastric mucosa, irritation, bleeding, etc. So, and more importantly, the risk that it may fall off anytime. So you need to explain to them why not NG tube and why we need the PIC tube. The PIC tube can stay as long as we need it. So you need to mention that. Very important to mention, can be easily removed as soon as we don't need it. Very important to mention that. The placement is usually whether endoscopy or surgery or radiology, you need to explain, is usually quick and it's not a major surgery, most of the time under local anesthesia, although some cases will be general anesthesia. So you need to reassure them. Most importantly is this phrase. Let me change the color. Always make sure mention that can be easily removed as soon as we don't need it. That's very important. The other word you can use reversible, because that gives them reassurance. And then very important, tell them that the tract or the hole will close within 2 to 3 days. In most cases, that hole in the abdomen will not remain there. That's very important. And most of the time, these families will agree to proceed with PIG tube. Then the next thing you need to, which one are you going to consult? Which physician are you going to consult? GI, interventional radiology, or surgery? My personal advice is whoever you feel has the most expertise, the least complications, I would call. Because believe it or not, they overlap, because surgery sometimes they can use endoscopy to put, or fluoroscopy to put the PIC tube, or they can use the open approach or laparoscopy approach. IR mainly use a fluoroscopy, and GI we know use endoscopy. So that's one thing. And the other thing, look for the possible or special consideration, like somebody who has like no esophagus. Of course you cannot perform it endoscopically, and you need to go either with IR or surgery, right? Also pay attention, somebody has gastric varices, you cannot perform with IR or GI. If we have to have a PIC tube, then get surgery to evaluate the patient, because still they may not do it. The ascites, if it's a must to have a PIC tube, make sure you tap this patient, control their ascites, get paracentesis, optimize their diuretics before you put a PIC tube, because the next thing you will see the acidic fluid start leaking from around the PIC tube, and the risk of peritonitis, etc. Pregnancy is not, or obesity, they are not contraindication, but they could be challenging. But any one of those with good expertise can perform that, but make sure you have a good care of that. And infection, abdominal wall infection, need to be treated before you consider putting any PIC tube. And the last thing we really need to actually one more is previous abdominal surgery. Also need to be careful. And again, the GI or IR surgery, they will be able to identify any anatomical problems, and they will not miss a bowel with the stomach, hopefully. That's why you should go to the one with the most expertise. Now prepare your patients for that. What I mean, once you decide that the patient needs PIC tube, make sure you look at their medications. Is there any medication need to be held? And mainly we're talking about antiplatelets, like we're talking about prasugrel, clopidogrel, and ticagrelor, that used mainly when we have PCI and cardiac stents. Those, most of them needs to be held for 5 days. Again, the way approach, I ask the person who will do the procedure, how long you want us to hold this? And again, from the moment I know the patient probably needs PIC tube, I should hold them if I can hold them. And if I have any doubt, check with the person. Let's say the patient had a cardiac stent, I check with a cardiologist about if it can be held, especially if it's less than a year, placed in less than a year. Also, the next thing, anticoagulants. Mainly we're talking about rivaroxaban, the apixaban, and I think the other factor 10 inhibitors, Pradaxa, I think that's the brand name. These need to be held at least 2 days before the procedure. Now there are some few exceptions, and this depends on the person who will do the procedure, but in general they want you to hold. So as soon as you start thinking about placing these PIC tube or any other procedure, it's better to hold these if you can hold them safely, or you can bridge here with other blood thinners, so that way you don't delay the procedure. And remember to keep them in PO the night before the procedure.